Great. So first thing I'll say is thanks for inviting me. What a great group of diverse and very interesting speakers, ranging. We're ranging from cells to society here, which is pretty brilliant. So I'm with the Department of Epidemiology in the Mailman School of Public Health at Columbia, and I am an epidemiologist, but also a little bit of my background is that I have a background in emergency medical services and have worked at the federal government some time ago, where much of this work began in terms of disaster response and thinking about preventing untoward effects of disasters, of a variety of disasters, but also what the medical system could provide for this. And I'm going to give you some of the background work on this, and then briefly what we've been doing, and a couple of papers that are emerging from our current work with the COVID-19 crisis. So this is a great piece to start thinking about. This is from Fred Cuny in 1995, and or 1993, I should even say. And I think Fred passed away in 1995. And this was he was a great humanitarian and disaster response planner. Did a lot. And part of this is that his work was this recognition that disaster response and preparedness is part of a larger cycle. We are only in the response phase, and this cycle then moves through evaluation and into preparedness. And frankly, you're supposed to learn from the evaluation and then be prepared for the next disaster when it occurs, which it will. And frankly, we've been assembling too much of the response while it's been occurring. And so part of this whole notion that we started years ago, and that lost steam because the federal government and others lost interest in it, was to build and validate some tools so that we could be prepared for later. Now, so I want to talk about the basis of some of these tools, and it's essentially looking at the difference between supply and demand. So the supply I'll be talking about here is the resources of the healthcare system that are either available or can be made available to respond to a disaster. And the demand is the high volume surge of, it could be injured, it could be ill, or it could be people that have passed away. And I want to talk about demand in three forms. First, I'll tell you about the work we've done in the past that's led to some of the models you'll see here in mass casualty trauma. Things like bombings, or could be earthquakes, which are also related to the second form of demand, which is a natural or climate disaster. And then the one we are currently in, a pandemic or infectious disease disaster response. And really, when you look at supply and demand here, the intent is to minimize unmet demand, and that is to avert, quote, preventable death and disability. Yeah, and when I say preventable, in any disaster, there is an element of folks who it's just not preventable, the death and disability. But we want to act as quickly as we can to manage those that are, and make as many of them as possible preventable. And then the other side of that coin is to minimize unused supply. In this case, I'm going to be talking about the healthcare system. But we first want to minimize our under response. That is, we don't want to have enough, we don't want to have fewer resources in our supply chain than needed to respond. But I also want to say we want to very much minimize over response. And I had started looking at this whole modeling effort, first doing some analyses for the Oklahoma City bombing long ago, but then for September 11th. And in some of the work talking to responders at September 11th, over response was a very big deal. There were folks who were called in. I was talking, for instance, to cardiothoracic surgeons who had come in from Nebraska, for instance, right? And some of those surgeons were talking about they had really not seen a patient over the weeks that they were in the New York region, but they were concerned that being called in from far away in Nebraska, that their patients didn't receive life-saving surgical procedures. So we want to have an appropriate response in terms of our supply use. Very first, not an under response, but also then concern ourselves with not an over response as well. So we took this work and this was a combination, I'm talking about mass casualty trauma now. We took this work and looked at trauma centers around the nation. This was with the American Trauma Society and the University of Pennsylvania over a decade ago. And we looked at trauma center hospitals, which represent about 15% of the hospitals in the US. And we discovered that the purple here, the red dots are the trauma centers across the US. And this is in 2010. And we discovered that about 85% of US residents could get access to a trauma center in an hour. And an hour is very important because trauma, being severely injured, is a very time-critical disease. You need to receive surgical care within an hour to improve the chances of your survival. The purple are the areas of the US where you could get that within an hour. So that is effectively the supply. Now I'm going to switch the purple here and show you the next map. The purple is actually the blue here, right? So I'm looking at the same supply map of getting access to a trauma center. And then we compared that to demand. And this is where the highest trauma rates were in the US. And when you overlay supply and demand for the US, this is a really quick visual, you get a sense of here the purple is where supply and demand have properly met. And the red is unmet demand. And the blue is potentially supply where there isn't the highest level of demand. Okay, so this supply-demand interaction is really, really important. So we went on to take that same information and work with colleagues, again, at Penn, but at Johns Hopkins also, and also in the federal government with the Assistant Secretary for Preparedness and Response at HHS, to do a simulation model for the treatment of trauma patients in disasters. I will say that this work was funded early on by the National Library of Medicine and the Centers for Disease Control, and my work at HRSA also informed this. I do want to state that the National Library of Medicine funding was more than halved over the course of our study, not because of anything that we did, but because interest in this kind of simulation modeling in preparation for disasters went away, and the Centers for Disease Control removed their interest in this kind of disaster response planning. So that was not part of the particular center we were working with. They stopped doing this kind of work. So the work was truncated at some point, and it would have been good to have this expand for later use. But we did manage to do a number of things. So I'm going to show you one of the main things here was that we simulated two kinds of disasters, fast onset and gradual onset. I'm only going to show you a fast onset approach, and fast onset here is as if a bomb went off or there was a sarin gas release or something like that, and there were a lot of people affected in a single epicenter all at once. We did this in 25 cities across the US for 5 different disaster sizes, ranging from 100 to 10,000 people. We used a optimization model, this mass balance dynamic simulation model, which I'm happy to talk about more. And it was a model to optimize distribution of patients along a network to their hospitals from that point location of an epicenter. Effectively, we took numbers, so you can see at time 0 where the disaster occurs, into time 1 where people are triaged into various levels of the disaster, and then they move through phases of the disease. In this case, we are talking about trauma, but they move through various phases. Some of them pass away, others are able to go home, and then a decent portion go into the hospital and then move within the hospital, from regular floor beds to critical care beds to operating room beds. And I want to stress the importance of the critical care beds. For trauma, also the operating room beds, but for the situation we're in right now, the critical care beds are a choke point for the system that are really, really important. So we used a number of these different, the percentages you see are drawn from people's prior experiences in disaster response, clinicians' prior experiences, many published reports. Many of them actually, when this was done, a lot of the information we received was from the Israeli disaster response system and a lot of their processes in hospital. And this was published in 2016, this paper. And we were able to do this for a number of cities. So for instance, here's Philadelphia. These are the hospitals are the points here, and you can see the time frame going from yellow to blue. We gave it a 48-hour period in terms of distributing the patients if there was a single point disaster in Center City, Philadelphia, distributing them throughout the region, what it would take, and this was for, I think this was for 10,000 patients, yeah? But you can see the same thing. We did the same thing for the other 24 cities. Here's a map of Denver looking at this. Here's a map of Tampa looking at this. And then if you went across the US, you get a sense from 100, if we did 100 casualties, you can see the span of the health system need to 500. You can watch these start to expand to 5,000 to 10,000. And you also get a sense of where the overlap is for these in terms of the need for the supply to respond to a mass casualty disaster. So where does that leave us for today? So that's mass casualty trauma, and that's sort of the basis, the particular type of disaster response model that we use as a basis for then looking at what about the COVID-19 pandemic. And in this case, we took demand that was mass casualty trauma and we basically swapped it out. Now it's a different form of demand, of course. So it's not a single point where there's a series of high volume people all at once in a single point. But we were fortunate to get together with people like Wan Yang, Sen Pei, and Jeff Shaman, also all at Columbia Mailman, who have been doing projections of the, and I think maybe Jeff spoke in this series at some point earlier, they're doing projections of COVID-19 patients needing critical care. And we know we have some good numbers, just like people were just showing you, distribution numbers in hospitals around New York, but also information that has been obtained from China or from Italy that informs where this is going. We did this for 21-day and 42-day horizons. We then looked at it in 4 reactive patterns of contact reduction. 0% meaning as if there had been no social distancing, 20% as if there had been 20% social distancing on up to 30 and 40% social distancing. We also looked at this in 4 hospital surge response scenarios. I'm just going to show you a few of these, but they were very low, meaning basically the steady state. Very low is just where the hospital system was in the absence of any kind of critical surge. Low is some form of surge response and preparation, medium on into a very high surge response. And I'm showing you our data visualization at the bottom that accompanies this. And Andrew Rundle is going to follow my talk. And he's going to show you both the mapping product that we have here and the data visualization and talk about all of these in more detail. And give you the website so that you can go to them. Now, contact reduction, the demand here, there were a couple of things that came into it. So this was, Jeff and his group did adaptive adjustments to contact imposed by government relations was one, things like school closures, restrictions on mass gatherings, as well as self-regulation by the population. That is self-isolation, if you knew someone, if you had been in contact, wearing of masks, and general social distancing. These were brought into the demand models that predicted what the medical system was to expect. And how much of the curve was basically, this is an exercise on flattening the curve. And would the medical system be able to, quote, take a punch? Could it withstand this kind of volume coming through its doors? We then came and established, based on prior work, but also a little bit more on the fly from what we were learning about the COVID pandemic, of the hospital surge response supply side. We used data, a variety of data sets from CMS, from the American Hospital Association, and the Health Resources File at HRSA. And we did this for all med-surgical hospitals in the US, and we brought in all long-term acute care facilities as well into this, because they also have the choke point here.
You have 1 minute, Charlie.
Care resources. Okay. So you can read the low, medium, and high intensity surge response. The low was something 30%, where some percentage of beds could be cleared and additional beds could be added in. The medium was the same, except additional beds would be added in. And in the high intensity response, we added in this, we learned it from Columbia collaborators like Neil Schluger about the ability to put 2 patients on a single ventilator, and we added that in. Basically, I just have 2 more slides to show you some of the findings. Basically, if you look at zero social distancing, with no contact reduction, it's a very different map in the low, medium, or high levels than even a small amount of social distancing in terms of the counties across the US that within the 42-day time horizon would exceed their capacity, okay? So the medical system, going from low to high, there is definitely lives saved, but there's a large number of lives saved by social distancing. And that's part of my final message here. We estimate that about 100,000 lives could be saved, deaths averted with aggressive hospital critical care using crisis standards of care. So I think it's important to point out the bravery and the courage of our medical providers who are putting their lives on the line to do this, to perform these saves. And then also that is compared to about 3 times as many deaths that could be averted from the very beginning via contact reduction compared with hospital critical care. Future things that we're doing right now is location allocation. We're doing some integer programming to begin to look at staffing and medical equipment redistribution, optimizing that. Andrew Rundle will show you the interactive, the web-based mapping and the data visualizations. And then I'll say, I would like to have us be better prepared the next time. I'd like to see an all hazards preparedness and response tool that, when I say all hazards, I mean for pandemic, for the future pandemic, for natural disaster, and for mass casualty trauma, and perhaps something along the lines of a national real-time electronic medical record. If hospitals could somehow get together to provide this up, would really serve this, this tool if we could build it as a nation going forward. Thank you. I hope I didn't go too far over.
Thank you, Charlie. I have a quick question, actually. When you use a value of 20% for social distancing, does that mean 20% of the population nationwide is observing social distancing? Or is it that 100% are observing it, but it's only 20% effective, or something in between those two? And do we have any sense right now what the actual value is and how that value changes across the US?
It's a fabulous question. I mean, the 20% we set based on known figures from prior information from China and Italy and elsewhere in terms of what its impact would be on cases and then severe cases that made it to the hospital and so forth. We do have, and I know Jeff Shaman and Wan Yang are bringing in data right now on mobility patterns that we're obtaining from cell phones. So to get a sense of, so the 20% is if 20% manage to effectively social distance. That number may be very different, could be as high as 40 or more, depending on, you know, mobility patterns with cell phones might be a nice proxy to figure out what that exact percentage is. And it's not for the nation, by the way. These estimates are done based on information that's obtained on a per county basis in the US. And then, so this is all being shown on a per county. And that was one of the things we wanted to do more of here. I know there's been a lot of projections done for the nation, of course, but also for states. But we really wanted to offer some thoughts on the local level so that county managers could prepare, and also so that if there was a need for resource redistribution, it could be done county to county, perhaps within a state. And in fact, the US Army Corps of Engineers, the US Air Force, and others who are doing this kind of resource allocation have been using the maps and the findings here.
Charlie, if you could take your slides down so that Andrew can get ready. And while you're doing that, I'll just ask, are there any other questions for Charlie from the attendees? From Margaret. Go ahead, Margaret.
Charlie, thank you for your talk, and also following in on what Dr. Griffin talked about. And I think most of you know by now that, you know, I'm on faculty in the history department. I'm a historian, so I look at these things through a different lens. And I just am wondering how you feel about this, but it strikes me that, you know, where modern democratic governance is about looking after the common good of the people, that we are, in some respects, you know, looking at one of the greatest failures of governance, frankly, perhaps since the dawn of modernity. And, you know, all of these little things where the CDC, you know, I guess as a result of some sort of bureaucratic rule, it wasn't possible to conduct testing on the Westchester patient. I mean, this is ridiculous in my view. But again, Justin, what you're talking about, I'm wondering about why their preparedness is not there. It is not as if we have not had pandemic scares over the last 10 to 15 years or so. Again, you know, we have had crises in the past. You can think about Katrina and all of these sorts of things, but they've been isolated to a particular place. This is more on a national scale. What are your thoughts about that?
So my first thought is that, boy, we need a historian to write this all up and get it noticed. I think you're absolutely correct that we have not documented the failures in investing in this. There was a great deal of investment after September 11th in the bioterrorism era. You know, that kind of fear did drive investment, but then that investment petered out. And that could have been taken in a number of different directions. And look, to be fair, there are agencies that have been thinking about this all along, but frankly, they've been marginalized in the ear of the major decision makers at the federal government. So we're not prepared as well as we could be. And, you know, there's a lot of, the US medical system is one example. You're seeing a lot of cooperation among health systems right now, but in general, they don't cooperate. They compete with one another. We need a bit more of co-opetition, and we need to establish that ahead of time so the system is ready, both the medical side of the system and the biologic response side of the system, so we're ready for the next pandemic, which is going to happen.